Thank you for being with us, Dr. McIntyre. Could you please start by introducing yourself, telling us what is your area of expertise and what would you like us to call you?
Well, you can call me Roger. I'm Dr. Roger McIntyre, professor of psychiatry and pharmacology at the University of Toronto. I have professorships at 2 universities in the United States and 2 in Asia. I'm a psychiatrist. I'm an academician. I'm a researcher. I'm also the head of the scientific advisory board for the Depression and Bipolar Support Alliance. And I have spent my entire career in trying to identify what causes depression and its unfortunate outcomes like suicide, and how can we cure those problems. So causes and cures of depression, I guess you could say broadly, has been my mission in life, and that's what's kept me busy for a long time.
We really appreciate your time with us today. We know and understand that the pandemic has changed all of our lives. And we know that there has been reports that basically since the pandemic started about suicide rates, people committing suicides, different age groups. Is this true? Has suicide rates increased with the pandemic, caused by the pandemic, during the pandemic? Could you please walk us through this a little bit?
Yeah, absolutely. And it's such a critical question. And, right across America and around the world, this topic has become really a international point of conversation. As they say, it's complicated, and it is complicated. And I think what we're all looking for is a summary statement, a nice summary statement that just provides a overarching summary of the truth. It turns out it's not quite that easy. A couple of points. What we do know is that suicide rates in most studies in most high-income countries, the United States, Canada, much of, for example, Western Europe, haven't changed a whole lot. In fact, there may be a slight decrease in some national suicide rates reported. We've also seen in other countries, however, that suicide rates may have had slight increases at least several months after the pandemic started, for example, in Japan. Why I start off with, just frankly, it's complicated because it is complicated. What we're learning is that it seems to break down along socio-demographic lines. For example, in the Japanese experience, what was reported was the suicide rate had increased in women, but not in men, several months after the pandemic. There's been other lines of research, a replicated finding that younger people seem to be at higher risk of suicide, more so perhaps than some of the older people. Thirdly, another demographic that's emerging is we are seeing in some studies, perhaps African American, perhaps Hispanic, maybe at higher risk, especially younger populations. It's been very complicated because when we came into the pandemic, we had a history as lessons approach. In other words, we knew from the SARS epidemic of 2003, the Great Recession more recently, and going back to the Asian financial crisis, the Great Depression, that macroeconomic shocks are often associated with an increase in suicide. But we have to remember something. Suicide is never caused by a single event. No one has ever died by suicide because of one reason. So you have a confluence of measurable and immeasurable variables that are mixing together. For some people, they've been resilient. Other people's, it's been a time at risk. So it is complicated, and it's fluid, and it's changing as this pandemic goes on and on.
Is there a specific, you mentioned that there can be differences with gender and age groups. Which ones of these age groups have suffered the most from this?
There is an epidemiologic story that seems to be unfolding across many countries that younger people, and I'm going to say under the age of 30, 35, but certainly the age of 30, seem to be at higher risk of thoughts of suicide, attempting suicide, utilizing mental health services or emergency services because of self-harm behavior, and in some countries like Japan, an increase in suicide, especially women. And that has been an observation, in other words, the observation of a greater vulnerability in younger people. It seems to be cutting across many countries. Again, we revisit the important reality that suicide is never caused by one event, and simply being younger would not be sufficient for this very tragic outcome. But it is, in fact, in keeping with a separate observation that's been made for quite some time, and that is that younger people are also more likely to report themselves as lonely, socially disconnected. We can conjecture that in part this is maybe the dislocation of schooling in person. Of course, that's not just a place to be educated, it's a place to form relationships and have a sense of support. For others who have started their early careers, they're no longer in the work environment. That's disconnecting and amplifies loneliness. I don't think it's the only factor, but this is a factor that we just cannot not take notice of insofar as we have a pandemic of loneliness around the world, especially in our younger population. So that demographic especially is at higher risk. But again, it depends on the country, and even across America, it even depends maybe even on the state. So these are where details matter as we try to arrive at not just a accurate quantitative of this area, but we're obviously interested in learning more. We want to prevent this tragic outcome, and these data points are going to be instructive as we try to really, find strategies to reduce suicide in our population.
I just wanted to ask Dr. McIntyre something. I'm so sorry. You had talked about people being at risk for suicide, right? If you could break that down a little bit for us on what are some of those risks that we should look out for or other people should look out for when a person is probably thinking about committing suicide.
Yeah, it's a really important point. We know that not everybody in our population is at equal risk, and we know that there are some people who are at greater risk than others. Now, it needs to be stated that suicide is not a mental illness, but most people, more than 80% of people who die by suicide, have a mental illness, and depression is the most common mental disorder associated with suicide. So someone with depression would be at risk. Now, just to in fact maybe put a fine point on something, research into suicide has revealed dozens, in fact, in some studies, over 100 risk factors for suicide. So there's many risk factors, and I think this is where it gets very difficult. And this is where we need to remind ourselves that a risk factor may be putting you at greater risk, but it may not have sufficient or powerful prediction. In other words, we know being a male is a risk factor in the general population for suicide, women at higher risk, but clearly its ability to predict future suicide behavior is very, very low. Unfortunately, in 2021, 2022, despite all of the research in suicidology on risk factors, we're still not that much better than flipping a coin as to who in fact is going to harm themselves. So this is where, in fact, it's been very frustrating. That being said, we do know that there are situations. Someone who's more socially isolated, someone who's had an abrupt change in their social, economic situation, someone with a mental illness. We're, of course, very concerned about access to firearms, which has increased in certain circles in the United States. And this, again, this is about creating a portrait of risk in its totality. It still remains a very difficult calculation, but those are the factors that immediately jump out. Can I add one additional point? One additional point I wanted to add is that part of the deliberations on in the United States and elsewhere, like Canada and other high-income countries, that attempt to really unravel the answer to this question, is suicide rates, are they changing, and if so as a function of which group, is that these data sets take a little while to accumulate, either from the CDC or other national health authorities. The other part, which is making life a bit more complicated, is the opioid crisis. Canada and the United States are the only two countries that are going through an opioid crisis. Canada and the United States have seen a massive increase in opioid-related fatalities during this last 2 years. Now, we are hearing from authorities, including law enforcement and other authorities, that this is explained in large part because of supply chain disruption and access to fentanyl and other lethal, high-potency opioids, and that certainly is well established. It's also not mutually exclusive of the possibility that some of these people have died not unintentionally. In other words, it's difficult for us to say with confidence that none of these people have committed suicide. We don't know that. And so that's another part of this equation I think we need to just be aware of, and also affects the total count here, because we're not entirely sure how many of the fatalities due to opioid overdoses are actually accidental.
That's a really great point. And I wasn't even thinking about that. When it comes to the opioid, and I know this is off topic, but when it comes to the opioid crisis, are there any instances where you've seen, probably in the news or in some of the research that you've done or read,
Yeah.
where the person who died from opioids, for a fact it was a suicide?
100%. And we do know that, in fact, that people who have depression, which is the mental disorder most often associated with suicide, have very high rates of not just substance use, but also alcohol use related problems. And we have plenty of examples, my own personal experience and in my own clinical practice. And so I'm aware of this through discussions with other colleagues, that there's no doubt that there are some people who have died by opioid-related poisonings and fatalities, where in fact the evidence does indicate it was actually intentional. Again, it's very difficult to quantify this. In fact, to be perfectly frank, it's immeasurable. We don't have an exact science to this. But I do think whatever that number is, it's probably more than zero. In other words, it would be impossible to argue that none of the deaths due to opioids that increased in the last 2 years are due to suicide. I think that would just be not in keeping with what we know. So I think that statistic needs to be considered alongside the data the CDC's been accumulating, and other countries, of course, in our analytic. And in Canada, like the United States, we also saw a decrease by about a few percentage points, it seems. Again, this provisional data, because the data are still being confirmed by coroners, a decrease in suicide. But we did see a significant increase in opioids. It seems from law enforcement, this is largely due to supply chain, as well as insufficient access to treatment centers and case management, things of that nature. But I don't think anyone is saying that this is all because of that. And there's some type of number in there that we just need to be very sensitive to.
Can we circle around back to the children? So when we initially started researching the story, one of the topics was, kids are committing suicide at an alarming rate. And just based off of the data that we've seen, there's an increase. I don't have the age group right in front of me, but school-age children up through college, right? Can you talk about that on why this is happening so much, and what can parents do about it?
Yeah, it's a really good point. And I think that there is a replicated finding that younger people, and again, how do we define younger? But younger people for now we'll define as under, say, 25 to 30, but you're getting at even a more refined and granular definition, maybe those between 12 and 19, for example. And that's a really important place to look carefully at. We are seeing, for example, an increase in emergency room utilization because of self-injury, intentional self-injury, or suicide attempts, or frankly, suicide. We're hearing about this now in younger people. And again, it's after 20, 25 years in this area, I'm always humbled by the fact that we don't have a singular pithy explanation. It's really a complex confluence of events. I do think that it's not a secret that we've had telehealth, virtual health, e-health, and these things have provided an opportunity to facilitate timely access to high-quality psychiatric first aid, but that's not always available to people. Not everyone has that. The other part is that we know that when it comes to the management of a younger person with depression, it often involves the family as well, and that's not always lending itself during COVID-19 to, in fact, for its appropriate treatment. But I do think, in fact, what for me stands out is, first, they probably have an underlying mental illness, like depression, more times than not. And I do wonder about the dislocation that we've seen in young people, especially the younger, 12 to 19, for example, not being in school. In some cases, I'm hearing people have been in school for a year and a half. Now, that's beyond measure in terms of the impact that has on someone's sense of social connectedness. Now, of course, as you know, many people can just hop on Instagram or Facebook or Twitter, but that gets complicated as well because we know that there is a complex relationship between social media utilization and mental well-being. We did a study in China where we found that the more time during the pandemic you spend on social media, the worse it is for your mental health. So that's not a solution for many younger people. That, along with the pandemic, that was the prodrome to this situation, that being the loneliness pandemic. You know, Dr. Vivek Murthy is the Surgeon General of the United States currently. He was before with President Obama. And when he was the Surgeon General during President Obama's terms, he made the point that he thought that the loneliness epidemic in America was a serious public health crisis. The changing work environment, the so-called gig economy, the virtual economy, absolutely has advantages for many people, but has disadvantages for others. For many people, it's the only place they can connect with people and have a sense of social, social belongingness. So I don't think that's the only factor, but I do think that you have complex mental illness related matters. You have an incredible fracturing of their social structure with school, and if they just recently graduated and maybe into the young work careers. And then you have this already situation well described, this loneliness pandemic, that rates are extraordinary in this area in terms of people feeling quite alone and feeling they don't have meaningful relationships. And they don't describe Twitter, Instagram, and Facebook as being meaningful relationships for them. So these are factors that I think are adding up. One final point I want to just put on that, when we talk about stress comes in different shapes and sizes. And I don't think, look, acute stress is probably a good thing for many people. In fact, if you had acute stress before a job interview, probably is good for your performance, or acute stress before a sports game, it's probably good. But when stress gets too much and too long, chronic stress, that's when we start getting problems. But what the biology of stress research tell us is that it's chronic, unpredictable stress that's the worst type of stress. COVID-19, now with this new variant we're hearing about, what you're really in fact hearing is that we just don't know when this thing's coming to an end. So it's one stressor to in fact lose your job, lose your schooling, lose your social identity. It's a second stressor to be quarantined. It's a third stressor, entirely separate, to have an event that you never know when it's going to end. And you keep hearing that the ball keeps getting pushed down the field here when this thing's going to end. So this is a combustible mix. It is negative for everyone's mental health, some groups more than others. And I just think that with younger populations already coming into this with already alarming rates of loneliness, I think that just adds to the combustion. Again, not the only factors, but those are factors I think that are well described in our literature.
Thank you so much, Dr. McIntyre. Maurizio, Aaron, do you have anything?
I do not, but I will say thank you so much for putting these, our research into like a more easy to understand, providing us information that is easy to understand for us.
Oh, great. Hopefully it wasn't too confusing the way I presented it, but I'm happy to cover the topic, and thanks for covering it. And if I'd love to see a clip if you have a clip at some point that gets picked up.
Oh yes.
I have one more question, Dr. McIntyre. Is there anything that we didn't ask you that you think it's important for our audience to know? Because while it's safe to say that certain suicide rates have increased, but you say that it's hard to quantify. But besides that, is there anything else that you think it's important for our audience to understand?
I do. And I think that the audience should understand that there are solutions. I don't think that the message is that this is doom and gloom and we're all doomed. I don't think that's the message. I think that, look, suicide is very modifiable. And I would say that any person, younger person, any person who is feeling distress should reach out to a care provider and should seek solutions. And the treatments that we have been shown to lower suicide rates. This is not something that's a fait accompli. It's something that's modifiable, and that's not meant to be a kind of a silver, sugary coating. It's a fact. It's a scientific fact. And so I do think, in fact, people should be left with that message. They don't need to, in fact, be, in this experience.
Thank you so much. We will let you know if we have any follow-up questions, and we'll do
Great.
our best to send you our story when it gets published. Thank you so much for your time.